Good afternoon, everyone, and thanks for joining us for today's OICR Mondays. The title of today's event is Immunotherapy in non-small cell lung cancer. Exciting emerging strategies. My name is Shola Dokun. I'm a senior program manager here at OICR. Together with my colleagues, Michelle Braza from Adaptive Oncology and Jay Ramnott from Therapeutic Innovations. We launched OICR Mondays about 2 years ago. And the goal of the discussion series is to bring together the cancer research community to discuss contemporary issues in the field and to identify opportunities for collaboration. So I would like to acknowledge that the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewas, and the Haudenosaunee and the Wendat people, and is now home to many diverse First Nations, Inuits, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. We also acknowledge that as a virtual meeting, many others may be on different territories. So please take the time to reflect on and honor the indigenous communities of your territories. So today's event will be 1.5 hours long, and we'll start with a very brief overview of our selected topic. And afterwards, we'll have 3 15-minute presentations from each of our invited speakers. The presentations will be recorded, and it will be posted on our YouTube channel. And after that, we'll have the open discussion session, which is our Q&A session, and that will be about 30 minutes long. And that is not recorded. So now I would like to introduce our moderator for today's event. She is Dr. Tricia Cottrell. She's an assistant professor in the Department of Pathology and Molecular Medicine at Queen's University. She's also an immunologist and pathologist whose research focuses on advancing clinical biomarker tests through studying tumor tissue specimens from patients enrolled in clinical trials. She completed a training, medical degree, PhD, anatomic pathology residency, and postdoctoral research fellowship at Johns Hopkins University. As a postdoctoral fellow, Dr. Cottrell was involved in one of the first neoadjuvant clinical trials of anti-PD-1 therapy, and was the first to characterize immune-related pathologic response following checkpoint blockade. Our areas of expertise include clinical trials, thoracic and genitourinary cancers, neoadjuvant immunotherapy, pathologic response, tumor immune microenvironment. Our research interests include mapping of complex interactions between cancer cells and the immune system, using multiplex immunofluorescence and digital image analysis, focusing on thoracic malignancies. Please join me in welcoming Dr. Cottrell to this event, and I would like to invite her to proceed with her presentation. Thank you.
Thank you for that lovely introduction, and thank you for the invitation. I'm delighted to talk about this topic as I have just returned from the World Lung Conference, and there's so much exciting activity happening. So let's see if I can share my screen. Okay, so I'm going to start by just giving a very brief overview of some of the highlights from the World Lung Conference. I think that's maybe one of the best ways to capture what's really new and exciting in non-small cell lung cancer. So one of the first things I want to talk about is the HARMONi-2 study of ivonescimab. So this is a novel first-in-class bispecific antibody that's targeting anti-PD-1 and VEGF. Sorry, it's targeting PD-1 and VEGF. And the idea is that it's not only reducing inhibition of the T cells, but also combating angiogenesis. And HARMONi-2 is a phase 3 trial that was in the first-line setting for advanced non-small cell lung cancer, comparing it to standard of care pembrolizumab. And you can see from this progression-free survival curve that the patients in blue who received ivonescimab actually had significantly improved progression-free survival relative to those patients who had received pembrolizumab. So the hazard ratio was 0.51. So I think this is some really exciting data suggesting that we may have some new standard of care emerging in the terms of this novel bispecific antibody. Another interesting bit of data that came out at the conference was the reanalysis of some data from a couple checkmate trials, and it was specifically comparing neoadjuvant versus perioperative approaches. So as we're all familiar, Checkmate 77T was a perioperative trial where patients received neoadjuvant nivolumab plus chemotherapy prior to definitive surgical resection, and then they had to have at least one dose of adjuvant nivolumab. That perioperative therapy contrasts with the pure neoadjuvant therapy that was administered in Checkmate 816. So for that trial, the patients got the pre-surgical nivolumab, but no adjuvant nivolumab. In using individual patient-level analysis of event-free survival and applying propensity scores weights to account for differences in baseline characteristics, the presenters demonstrated that the patients who received perioperative nivolumab had an improved event-free survival relative to those who received neoadjuvant alone. And of course, there are all sorts of caveats about comparing these trials, and it's not a direct head-to-head comparison, but some potentially interesting data suggesting that the perioperative approach may have advantages. The third drug that I'm going to talk about is hard to pronounce, datopotamab deruxtecan. I'm going to call it Dato-DXd. I became a pathologist, so I did not have to become fluent in drug names. And this is actually an antibody that targets TROP2, which is a protein expressed on cancer cells, and it's conjugated through a linker to a topoisomerase 1 inhibitor. So it's an antibody drug conjugate. And this specific trial that I'm going to talk about in this slide is the Tropion Lung 1 trial, which is comparing this Dato-DXd ADC to docetaxel in the second-line setting for advanced pretreated non-small cell lung cancer. Now, earlier this year, data had been reported for one of the dual primary endpoints, which was progression-free survival, and they had previously reported that progression-free survival was significantly better in patients who received the novel therapy. At the World Lung Conference last week, they came back and reported on the overall survival, which was a second primary endpoint, and actually the overall survival comparison was negative in this study. But there were a couple other interesting studies presented using this same drug, and one of them was near and dear to my heart. It was a computational pathology approach to actually predicting response to this novel therapy. So this particular antibody drug conjugate actually has to be bound and internalized into the cell in order to release the anti-topoisomerase 1 drug and kill the tumor cell. And the protein TROP2 is expressed in the cytoplasm as well as the membrane, and prior studies were unable to predict response based on expression. And so this computational approach using digital image analysis actually scored the membranous expression of TROP2 relative to the total amount of TROP2 that included the cytoplasmic expression. And as you can see in the purple line, they were able to identify a subset of patients who had improved progression-free survival when receiving the novel therapy based on this computational pathology biomarker. So I think some really exciting early data about the promise of this approach. And unfortunately, they didn't have the analysis for the overall survival, so we'll have to wait and see. And then finally, there was the NeoCOAST-2 trial, which is comparing neoadjuvant durvalumab with chemotherapy with novel agents. And Dr. Cascone presented on 3 arms of the trial, oleclumab, which is an anti-CD73, monalizumab, which is an anti-NKG2A, and then the TROP2 antibody conjugate that I was just talking about, which is in arm 4 in the red on this graph. And we're comparing pathologic complete response, PCR, and major pathologic response, MPR, So the patients received the triple combination prior to surgical resection, and then at surgical resection, we're looking at pathologic response. And you can see that the triple combinations actually increase the rates of PCR and MPR when compared to the Aegean data of durvalumab and chemotherapy alone. And the strongest signal was actually in the Dato-DXd antibody drug conjugate, where we saw 34% complete pathologic response and almost 66% major pathologic response. So some very exciting early phase 2 data suggesting that these triple combinations may really increase the rates of pathologic response, and hopefully that will correlate to improved patient survival. So that is that. And I will now transition to my 15-minute talk, when I'm going to focus on emerging biomarkers for lung cancer. And I apologize that I have the wrong background on my slides, but this was a talk that I gave at the World Lung Conference last week. And I have to say that I was very delighted by the positive response, and I think you'll see why in a minute. So the thesis of my talk is really that the practical and scientific benefits of adopting standardized pan-tumor approaches for biomarker data collection and reporting will improve care for patients with lung cancer. So obviously, speaking at a lung cancer focused meeting, not everyone agrees that lung cancer should get on board with everyone else. But like I said, I was very delighted to get positive reception. And I'm going to highlight this through 3 examples of emerging pan-tumor biomarkers. So the first is I'll talk about multiplex immunofluorescence and this interesting population of CD8 positive, FOXP3 positive T cells. Next, I'll talk about on-treatment pathologic response assessment. And finally, I'll share some early work that's been done to actually define essential biomarker recommendations for clinical trials. So this is my favorite slide. Multiplex immunofluorescence has really been demonstrated to be a robust pretreatment approach for biomarker discovery, and this is true across tumor types. So the ROC curve I'm showing you here is based on analysis of 55 studies across 10 different tumor types and over 8,000 patients. And what we're comparing is different pretreatment biomarker testing modalities relative to the actual response of these tumors to immune checkpoint blockade. And you can see in the green line that multiplex immunohistochemistry and immunofluorescence is vastly outperforming these other biomarker approaches, including the current clinical standard of care, which is PD-L1 immunohistochemistry, shown in blue. And I've been fortunate to train with and collaborate with the Astropath team at Johns Hopkins, and they've developed a really exciting collaboration between pathology and astronomy to develop a large-scale whole slide multiplex immunofluorescence platform. And so this is work that was published a few years ago, looking at predictors of response to anti-PD-1 in melanoma. And it was using a 6-marker multiplex immunofluorescence panel. And I think I have a picture in a subsequent slide, but really just basic markers: CD8, CD163, FOXP3, PD-1, PD-L1, and a tumor marker. And after image analysis, we can extract single cell data from all of these pretreatment biopsies and look at all these different cell populations, not only based on their lineage markers, but also based on their expression of PD-1 and PD-L1. And we can further subset those based on low, mid, and high expression of those markers. And the table that we are looking at is the top 10 most predictive cellular subsets that are associated with patient outcomes. And in this case, it's objective response in melanoma. You can see that the first 2 PD-L1 negative, CD163 positive cells and PD-L1 negative tumor cells are actually negatively associated with response, whereas the others are positively associated with response. And when you use this multi-variable biomarker, you get a very robust prediction of patient outcomes. And that was demonstrated in the subsequent separate validation data set that's shown on the right. So what you'll notice in this list of 10 cell populations is that these CD8 FOXP3 cells that we did not even expect to find are actually extremely well represented. And I have some data that I'm not going to show today using single cell RNA sequencing in lung cancer that suggests that these cells are actually early activated T cells. And so I've been leading a study in neoadjuvant non-small cell lung cancer where we had the opportunity to apply the same multiplex panel to pre-treatment and on-treatment biopsies from patients who received neoadjuvant anti-PD-1. And if you look at this heat map, you can see that our lineage markers are listed across the left with CD163, FOXP3, CD8, and then FOXP3, CD8 positive, double positive cells and tumor cells. And we have PD1 and PDL1 expression at the top. And the heat map is showing the AUC value for the differences in cellular densities between responders and non-responders across these different cell populations. So the higher the number, the better, the stronger the association is with, in this case, major pathologic response. And you can see that, and circled in red, the FOXP3 CD8 T cells are actually showing AUC values of roughly 0.7 to 0.8 and outperforming all the other cell populations, including tumor cells, PDL1 positive tumor cells, and CD8 cells. And you can see the ROC curve there showing that strong association between pretreatment CD8 FOXP3 cell densities and outcomes of major pathologic response in this setting. So I mentioned that we were able to stain both pre-treatment and on-treatment specimens. Here I'm showing paired pre and on-treatment specimens, and we're looking at the densities of CD8 and FOXP3, CD8 positive FOXP3 positive cells and how they change from the pre-treatment setting to the on-treatment setting. And the patients, the specimens are broken down by whether or not there was a major pathologic response to therapy versus non-major pathologic response. And what you can see is that in both columns, the densities of CD8 FOXP3 cells increase with treatment, but there's not a significant difference in terms of the densities on treatment between responders and non-responders. On the right, what we're actually looking at is a spatial analysis of the infiltration of CD8 FOXP3 cells across the tumor stromal boundary. So that dashed line in the center represents the boundary between the tumor and the stroma. The stroma is on the right, the tumor is on the left. And you can see in the green lines that patients who achieved either a major pathologic response or at least 50% tumor regression had higher levels of infiltrating CD8 positive, FOXP3 positive cells than those tumors where there was more than 50% residual tumor. And both of those are higher than the pre-treatment levels. So we have a lot of really interesting data in the works, and this is just kind of touching on this topic, but we think that CD8 FOXP3 cells have potential as a pan-cancer biomarker predicting response to immunotherapy, and we're subsequently going to be doing some multi-panel analysis where we can actually register serial sections and look at these cells in the context of immune phenotypes and different spatial organizations. So a lot more to come on that topic. The second topic that I'd like to touch on is the idea of how we're assessing pathologic response itself. And so this is work that started for me when I was still a trainee at Johns Hopkins. I worked with Janice Taub, and Julie Stein-Deutsch has really carried this work forward into other tumor types. And the idea is that based on pre-treatment and on-treatment specimens from that original anti-PD-1 clinical trial led by Patrick Ford in lung cancer, we were able to identify features that correspond to immune-mediated tumor regression. And Julie Stein-Deutsch has showed that those features are common across tumor and tissue types. And she has some really beautiful data from Checkmate 816, which is a phase 3 clinical trial that used this approach to assess pathologic response and ultimately led to regulatory approvals of neoadjuvant therapy. And what you can see on the right here is actually the percentage of residual viable tumor as it associates with 2-year event-free survival in non-small cell lung cancer. And, you know, we talk a lot about complete pathologic response or major pathologic response, but as you can see in this graph, at 10% increments, we have a continuous association with patient outcomes. And so, again, this is a space where producing really standardized data sets and reporting them in a standardized way is going to allow us to identify the most relevant cut points for future clinical trials in each tumor type. Based on this work, there is a Society for Immunotherapy of Cancer-led effort called PathData, which is pan-tumor harmonization of pathologic response assessment for standardized data collection in neoadjuvant trials. And this is a multi-stakeholder effort involving pathologists from all over the world. And we have 14 pathologists who scored 42 resection specimens and on-treatment biopsies from over 10 different tumor types. And these patients had received a variety of therapeutic regimens, including immune checkpoint blockade, targeted therapy, and chemotherapy. And the pathologists, regardless of their primary specialty, were asked to score these specimens in terms of the percentage of residual viable tumor in both the primary tumor and the lymph node. And what's really exciting is that we demonstrated that using this approach, we could reproducibly score pathologic response in primary tumors at various sites throughout the body, as well as lymph nodes and biopsy specimens. And so here you can see the intra-class correlation coefficients for the overall study, as well as broken down by primary tumor, PT, lymph node, LN, and biopsy. And you can see the list of tumor types with lung adenocarcinoma and squamous cell carcinoma represented. Now, what's really interesting is that as part of the study, they actually surveyed those 14 participating pathologists and asked them if they would prefer a standardized scoring system for pathologic response. And the overwhelming majority, 80%, said that they would rather use one scoring system instead of having individualized approaches for each tumor type. And these are people who had actually gone through the process of scoring tumor specimens from different sites. So we're really optimistic that this may be a streamlined path forward. So the third topic and last topic I'm going to talk about is one that I've been privileged to work on with Dr. Michael Lotz from the University of Pittsburgh. And this is another SITC-led effort. It came out of a clinical trials workshop that was started by Dr. Lotz. And this clinical trials workshop is uniquely focused on immunotherapy clinical trials. So early stage investigators with protocols that they're working to develop can bring them to this workshop in Austin, Texas, and they can work with a team that includes a clinician, a patient advocate, a biostatistician, and an immunologist. They can all work together to develop these protocols, and with the focus of really making the science robust so that regardless of the outcome of their clinical trial, we're continuing to learn things about the human immune system and how we can improve responses to immunotherapy. So at this conference, we realized that the landscape of biomarkers that could be included in immunotherapy clinical trials is really overwhelming. And we wanted to provide some guidance for those early career folks. We also appreciated that there wasn't really a standardized approach to collecting and reporting biomarker data across these trials, and that may be a real missed opportunity to interpret them with more nuance and also facilitate cross-trial analyses. So we all know that the patient's response to immunotherapy is dependent on numerous factors, some of which fall into cancer cell specific features such as tumor mutational burden or driver mutations. There are features of the tumor microenvironment like PD-L1 expression and CD8 T cell infiltration. And there are also patient-level systemic factors. We've heard, some really exciting data about the stool microbiome, but there's also really robust data about, neutrophil lymphocyte ratio being associated with resistance to immune checkpoint blockade. So really understanding how these three aspects of the patient and their biology are interrelated is important for understanding how they may or may not respond to a particular therapy. So the goal of this work is really to offer a set of essential biomarkers that we believe should be included in all early phase immunotherapy clinical trials. And this is based on strong evidence of clinical or biological relevance, robust data across tumor types and treatment approaches, as well as high feasibility. So we're talking about things that have standardized testing methods that are routinely available, ideally reimbursed. We want to be very practical about this. In addition, we discuss emerging biomarkers. We know that there are tons of studies that have shown early evidence of potential clinical utility. I showed you some exciting early biomarker data a few minutes ago. What these biomarkers may lack is robust analytically or clinically validated assays, And the hope is that we will ultimately be able to promote some of these emerging biomarkers into the essential category with additional data, or potentially remove them from consideration. So the vision of this effort is to publish. We initially published a commentary. We're about to submit a literature review that also includes an initial consensus-based classification. So we've surveyed all the faculty of the clinical trials workshop, as well as the members of the pathology and biomarker committees of SITC, and we've established consensus for our initial recommendations. And the idea is that this is the tip of the iceberg, and that we would continue to review the data as it emerges and offer updated recommendations about the best biomarkers that should be included baseline in clinical trials. So I hope I've convinced you that there is a significant benefit to aligning on these pan-tumor biomarker approaches. This offers the potential for standardization of assays and data collection and reporting, which will support robust meta-analyses and regulatory approvals. And this is important also for just efficient clinical translation of novel biomarkers. So I think everybody is well aware of the pain that was caused by PD-L1 and the different assays and the different scoring systems, and some of that pain is ongoing, and a lot of that could be eliminated if we were streamlining our approaches to biomarkers. This also will facilitate quicker analytic and clinical validation and adoption and implementation. And of course, standardized data collection and reporting does not preclude tumor-specific interpretation of thresholds that are meaningful in a certain context. So with that, I will stop sharing. And I would invite Dr. David Kwiatkowski to share his slides while I introduce him. So Dr. Kwiatkowski is a senior physician at the Brigham and Women's Hospital, Dana-Farber Cancer Institute, and professor of medicine at the Harvard Medical School. He's an oncologist and geneticist, and his major clinical and research interests are focused on thoracic cancers, especially mesothelioma, as well as immunotherapy response and MTAP as a therapeutic target. The mTOR signaling pathway and its role in tumor development, and the genetic disease tuberous sclerosis complex and all of its related tumors. Dr. Kwiatkowski has a broad interest in cancer genetics, with past roles in several NCI TCGA projects, including bladder cancer, lung cancer, and mesothelioma. He's trained over 70 individuals in his career, ranging from high school students to postdoctoral fellows, over 10 of whom are now professors at other institutions. His lab group currently consists of 4 postdocs and 2 instructors, and they are focusing on digital pathology image analysis to predict response to immunotherapy, immune checkpoint therapy, MTAP therapeutics and resistance, and molecular pathogenesis and targeting of TSC-related neoplasms. Dr. Kwiatkowski has practiced thoracic medical oncology for the past 40 years, and we're very excited to hear about his work in predicting response to immune checkpoint inhibitor therapy through digital pathology analysis.
Thank you very much. This is the title of my talk. So that picture is a picture of the Athabasca Glacier, which for the Canadians listening to this talk, you should all know about. This is apparently one of the most viewed glaciers in Canada, and it's located near Jasper, near the border with British Columbia, but in Alberta. And I had the pleasure of visiting there this summer, as you can see, in July, and we had a great time. And the second important thing is that much of the work I'm going to talk about is the work of Mirdad Raki, who was a postdoctoral fellow with me a couple years ago, and we have continued a collaboration, and he has returned to his home institution in Norway. So my talk will fit pretty well with what Alicia was talking about, or Tricia, sorry, in terms of her thoughts and views of this field of trying to identify predictive biomarkers for ICI response. Mine is very much focused on non-small cell lung cancer. So in terms of known markers, we know that PD-L1 levels are associated with response. It's really a continuous scale. The higher you go, the better your chance of response. High TMB, also a continuous scale, the higher the better. But we also know several gene mutations are negatively associated with response, including STK11, KEAP1, SMARCA4, as well as, of course, EGFR and ALK mutations. And kind of as mentioned already, we've known for a long time that tumor infiltrating lymphocytes can define either a desert environment, an altered environment, or an inflamed microenvironment near the cancer, and that these are strongly associated with response, although to my knowledge, they've never entered routine clinical practice, certainly not at my institutions. And then, so I'd like to review those, and I'd like to talk about some novel markers, which are MTAP deletion, quantification of TILs by supervised machine learning, and then a method that we have developed called DeepIO, which uses artificial intelligence interpretation of digital H&E images. Okay, so first to review a bit. So very high PD-L1 tumor proportion score is associated with improved progression-free survival and overall survival compared with 50 to 90% PD-L1 levels. So the higher you go in terms of PD-L1 score, the better in terms of response. This is from a substantial number, about 500 patients at several institutions, as indicated at lower left. And this work was done by my colleagues Biagio Raschuti and Mark Awad. And very high TMB, greater than 20 mutations per megabase, also correlates with improved progression-free survival and overall survival compared with less than 20. Again, a large number of patients here, 1,500, and again, studied by my colleagues. And then there are several genes in which mutations are also associated with worse response to chemo-ICI therapy. And this is predominantly seen or more strongly seen in tumors that also have KRAS mutations, less so in tumors that are KRAS wild type. So you can see here the hazard scores associated with worse overall survival, particularly in the KRAS mutation subset shown at the bottom here, where the hazard rate for worse overall survival is in the range of 1.5 to 2.5 for these three different mutations shown here. So then moving on to newer things. So MTAP is a gene on chromosome 9p22 that you should all be familiar with. This is commonly co-deleted with CDKN2A, apparently mainly as an innocent bystander event. But MTAP deletions are very common across cancer in general because CDKN2A is the most common deleted mutation in human cancer as a whole. And MTAP deletions occur in about 20% of lung squamous and 12% of lung adenocarcinoma. And we've recently shown and published that MTAP deletion leads to high MTA levels in the TME, which inhibits lymphocyte function, and is also associated with reduced response and OS to ICI therapy in both bladder cancer and melanoma. And I think this is also likely to be the case in lung squamous cell and adenocarcinoma. And then finally, you should be aware that PRMT5 inhibitors that bind to the MTA PRMT5 complex are in clinical trials from several pharmaceutical companies as listed there. And in particular, one of these drugs, MRTX1719, has been published and shown efficacy in phase 1 trials in multiple cancer types. But now moving on to analysis of pathology slides to try to infer response to immunotherapy or chemoimmunotherapy. So this was the first publication that we had in this area where supervised machine learning was done on H&E images to determine TILs as cells per millimeter squared within the tumor stroma. And this was a large number of patients, almost 700, of which about 2/3 were from our parent institution, the Brigham and Dana-Farber, and another 1/3 were at London and Amsterdam. And all patients had metastatic non-small cell lung cancer and all received mono-ICI therapy without chemotherapy. As you can see that this machine learning approach is fairly efficient at identifying both tumor cells, stromal cells, and TILs in this H&E image. And so if you take the calculation of TILs per millimeter squared and simply use close to the median as a cut point for above or below, you can see that there's an association with progression-free survival, both in the discovery cohort and actually more impressive in the validation cohort shown here on the right. And moreover, this is better than TMB assessment in the subset of patients who have 0% PD-L1 expression. So in this large data set, 50 of the DFCI patients and 66 of these patients had PD-L1 IHC levels of 0. And in this set, TILs had a better AUC than TMB and was associated with a better response rate, as shown here, upper right. Whereas TMB really was not effective at predicting response in the DFCI patients who had no PD-L1 expression. And again, TILs showed very nice differentiation between progression-free survival in these secondary validation cohorts from London and Amsterdam. So we then moved on from there and began to look in more detail at TILs in sections, and now here using CD8 and pancytokeratin IHC images. And this slide illustrates the three different categories of immune profiles that we see in lung cancers. So the one on the left is the immune desert, shown by pseudo-colored IHC and colored by the program that was used here, supervised machine learning, showing that there are very few lymphocytes in either the tumor or the stroma. They're colored in red here. Whereas in immune altered, there are more in the stroma and some beginning to appear in the tumor, whereas the immune inflamed really have a lot in the tumor as well as in the stroma. And so this analysis, these observations have been known for quite a long period of time, almost 10 years, I would say, but have not really been quantified or presented in large cohorts. And so this study was done in early stage non-small cell lung cancer, stages 1 to 3A. And this shows that in both squamous cell carcinoma and adenocarcinoma, that there was an improvement in disease-specific survival, as well as time to recurrence, according to inflamed, altered, and desert states in terms of the tumor stroma. Now returning to what Tricia talked about, MIF also has recently been done by my colleague Scott Rodig here at the Brigham, and work that's not published yet, but in preparation. And also in both non-small cell patients who were treated with immune therapy and those that did not, there was a prognostic significance to having the patients did worst who had the lowest tertile of immune cells defined by CD8 positivity in the tumor compared to those with either the middle tertile or the highest tertile of CD8 positive cells in the tumor. This didn't pull apart quite so much for the no immune checkpoint inhibitor therapy, but was similar, particularly for the lowest tertile of patients. So it shows that really this is a prognostic factor that's independent of immune response, but also serves to identify patients who will respond better to ICI therapy. Okay, so then the most recent thing that Mehrdad has pursued is what we're calling deep IO analysis to develop a prognostic AI-based feature for ICI response in non-small cell lung cancer. And so first thing I want to do is to say that, you know, people hear AI and it's like, oh my God, what is it? How does this work? What actually really is not so difficult to understand. And I'm going to try to explain this in the next minute or two. So what is done is that the H&E stain slides from patients are first segmented into tiles. The tiles are quite small, of size about 1/4 by 1/4 millimeter. And then they're reviewed to make sure that they're good quality, that they don't have a lot of white spaces on them, that they don't have pathologist crayon marks or other things. So those are thrown out, the colors are normalized. And then there's some class balancing to avoid oversampling of patients who did not respond as well to ICI therapy. And then those images are associated with ICI response for each patient. And then they're fed into a convoluted neural network that analyzes those images and allows the network to predict response to another sample that was not used for the training. And so this was done, again, on a large cohort, almost 1,000 patients. 521 were used for training and 93 for testing, all from our parent institution. And about a third, yes, roughly a third of patients at other sites, including London, Amsterdam, and now Rome. These patients all had metastatic non-small cell lung cancer. All the DFCI patients had OncoPanel, our panel testing for mutations, as well as PD-L1 IHC, all received ICI monotherapy. And then for testing, after the training is done, for testing, the probability of response to therapy is assigned to each tile independently. And then the DeepIO score is the average for all tiles for a patient. And so doing this again and looking at the high versus low by the DeepIO score, this showed an improvement in progression-free survival, as well as overall survival. This is showing survival curves for the external validation cohort from the 3 other sites. And in the validation cohort in particular, it's interesting that if you break this down to adenocarcinoma versus squamous, adenocarcinoma on the right, this worked very well for both progression-free and overall survival, and really didn't work at all well for squamous. And I think this is not surprising, since 2/3 of the patients or more were adenocarcinoma, and therefore that dominated the training. And so not surprising that this modeling approach would not work well in squamous cell carcinoma. And so again, using this AUC method, DeepIO had an AUC that was in the range of 0.65 to 0.75. It looked a little better than PD-L1 scoring in a DFCI test set of 93 subjects, and was similar to PD-L1 in the external validation set, and the combination appeared to be somewhat better. And in univariate analysis in the external validation set, again, DeepIO score looked to be somewhat better than PD-L1. Okay, so in terms of thinking about what's next, I agree with many of the things that Tricia said. We need standardization, we need other studies, we need comparative analyses. And one thing that's really important is multivariable analysis to determine which of these factors, mutations, DeepIO score, T-cell infiltration, nuclear lymphocyte ratio, et cetera, are most significant compared to others that are not. And this shows that in this multivariable analysis, again, done by my colleagues, but which did not include TILs or our DeepIO score, that performance status, nuclear lymphocyte ratio, KEAP1 mutation, and SMARCA4 were all independent predictors, as was very high TMB and high PD-L1. So we need more studies like this to help sort things out. So again, predictive markers for ICI response in non-small cell, just reviewing a little bit in terms of what's next. I think we need validation studies to enable translation to routine clinical use. We need analysis of associations of these features with response to chemo-ICI. Most of the studies I've reported here were done just ICI treatment, which, as you all know, is no longer standard of care for the vast majority of patients. It's now chemo-ICI for most patients with non-small cell, apart from those with high PD-L1 levels. We need multivariable analysis to identify driver factors. And we also need mechanistic studies to explain the mutation effects and develop better therapies. So thinking about from the clinician's point of view, so what do? We see a patient who's got metastatic either adenocarcinoma or squamous cell carcinoma of the lung, and we have a bunch of mutation data. We may have some MIF data. We may have some TIL data. How do we decide what therapy to use, and what alternatives do we really have? Well, as of today, really the only other alternative beyond chemotherapy plus and a PD-L1 or PD-1 agent is the combination of a PD-1 agent with a CTLA-4 inhibitor, as well as chemotherapy. And this is a slide from Solange Peters reporting that even in these bad prognostic subsets, STK11 mutation and KEAP1 mutation, that the combination here of tremelimumab, a CTLA-4 agent, and durvalumab, a PD-L1 agent plus chemotherapy, that combination of all three was somewhat better than durva plus chemo or chemo alone. So other trials, which mentioned again by Tricia, that are in development. So I'd like to thank many collaborators here, particularly Mirdad again, who did the vast majority of this work, but our important collaborators, Mark Awad and Biagio Raschuti, Mark having recently moved to Memorial Sloan Kettering. So I will stop there. Thank you.
Thank you for that wonderful talk. I look forward to asking you lots of questions at the end. We'll now move on to our third speaker. So I'd invite Dr. Thawani to go ahead and share your slides while I introduce you. So Dr. Thawani is an assistant professor at the University of Chicago. He's an oncologist and expert in lung cancer treatment and research with extensive experience in diagnosing and treating patients, including latest therapies, including targeted therapy. He's also well known for his compassionate approach to patient care and commitment to helping patients navigate their treatment options. In addition to his clinical work, Dr. Thawani is dedicated to advancing the field of oncology and improving outcomes for patients with lung cancer. He's actively involved in clinical research aimed at understanding how cancer cells grow and using that mechanism to study new drugs and clinical trials. Dr. Thawani's interests include treating lung cancer patients without a smoking history, as well as patients where standard of care has stopped working. In addition to developing new therapies and treatment strategies for lung cancer designed to reduce cancer incidence and mortality, he also focuses on improving survival and quality of life for cancer patients and has published numerous articles in peer-reviewed journals, including JAMA Oncology, Cancer Medicine, The Oncologist, and more. So I'm delighted for Dr. Thawani to tell us about some combination immunotherapy clinical trials in non-small cell lung cancer.
Well, thank you so much. I hope everyone can hear me. So I'll be talking about a lot of new things that have happened, including World Lung, and I managed to, snag some ESMO slides as well. So these are my disclosures. I think I just have this picture here. I'm not going to go over this figure per se, but this is just a small depiction of how complex the tumor microenvironment is and what are the different mechanisms by which oncologists, researchers are trying to combat cancer by inhibiting growth and activating the tumor microenvironment against the cancer. And all my talk is based on the backbone of PD-1 and PD-L1. So anti-PD-1, PD-L1 therapy has been the backbone of lung cancer for a while now. Initially, it was approved as a second-line treatment in non-small cell lung cancer across all PD-L1 expression. But since then, because of its success in a second-line setting, it's moved up front because of improved response rates, survival, and also durable responses. I'll just have this figure from a 5-year update from Keynote-024, where we see that some of these patients with high PD-L1 do really well. And in this curve, you can see that 32% of patients are still alive after 5 years, which was not the case many years ago. So the first, I'll be discussing different combinations to anti-PD-1 and anti-PD-L1. And obviously the first obvious combination is chemotherapy, which we already use as oncologists in patients with PD-L1 49% and low. This is validated over and over again by different drugs, different immune checkpoint inhibitors by different manufacturers. And we have seen that high PD-L1 patients obviously just do fine with immunotherapy with a 5-year overall survival of 30%. But patients who have lower PD-L1 below 50%, still require chemotherapy, but a significant portion of patients, 20%, PD-L1 1 to 49%, are still alive at 5 years, and PD-L1 negative patients, only 10% are. So this just reinforces the backbone of PD-1 and PD-L1 inhibitors, and then chemotherapy being the obvious combination partner for these treatments. And the other standard of care treatment that we use in lung cancer is radiation therapy. Again, there's lots of mechanistic ways by which radiation helps immunotherapy work better. It leads to immunogenic cell death, activates T cells, which further lead to T cell priming and effector T cells attacking the cancer. And theoretically, there's also this effect called abscopal effect, which is fairly controversial right now, but mechanistically can lead to reduction in cancer even at a distant tumor site. So the only study that I'll discuss here is Pembro-RT. Pembro-RT is a phase 2 randomized clinical trial where stage 4 or recurrent non-small cell patients were randomized into standard of care pembrolizumab or SBRT followed by pembrolizumab. And here, as you can see in the curve, that patients who got experimental treatment did better than patients who got control arm. Now, I want to point that this benefit was probably derived mostly from PD-L1 negative patients, where you can see that patients who got radiation did a lot better, which just reinforces that PD-L1 negative patients do not do just fine with pembrolizumab. They probably need more in terms of therapy to get the benefit from immunotherapy. Of note, this was a unique trial where patients only got immunotherapy and not chemotherapy. The other obvious partner is anti-CTLA-4, again, an approved regimen, approved along with anti-PD-1 inhibitors. So I'll briefly start off with anti-CTLA-4 and then discuss some of the other checkpoint inhibitors that we have combined. But before I do that, I wanted to show how complex, again, the tumor microenvironment actually is, how complex the checkpoint system is. And there are lots of checkpoints on T cells, dendritic cells, tumor cells that lead to T cell activation. And I think we've only scratched the surface in terms of having FDA-approved therapy with just PD-1, PD-L1, and CTLA-4, LAG-3 now more recently in melanoma, but there's so much more to uncover here. And with that, I'll talk about CTLA-4, which is the approved partner in non-small cell lung cancer. CheckMate 227 has been a while since this study has been published. This was a study in stage 4 or recurrent non-small cell lung cancer where patients were randomized into receiving nivolumab plus ipilimumab, histology-based chemotherapy, or nivolumab, with the dual primary endpoint of PFS and overall survival. And what I wanted to show here was just the patient with response. And you can see that the addition of ipilimumab definitely increased responses than nivolumab in both patients with PD-L1 positive disease and patients with PD-L1 negative disease. But you see the magnitude of increase is probably numerically higher in patients with PD-L1 negative disease. Again, which just reemphasizes our point that patients with PD-L1 negative disease need additional help in leading to T cell activation and an immune response to fight cancer. And I think from there on, I'll go over to something that's hot off the press. So some slides from ESMO. I'll talk about Relativity 104, which used LAG-3 in addition to anti-PD-1, so nivolumab and relatlimab, in addition to platinum doublet chemotherapy, randomized with nivolumab and platinum doublet chemotherapy as frontline treatment for stage 4 or recurrent non-small cell lung cancer with a response rate as a primary endpoint. Here, the responses were not as impressive, where we see that there's fairly, enough crossover to not be that excited with this data, and a hazard ratio of 0.88, and the confidence intervals crossing 1. And again, here in terms of response rate, fairly close response rate, numerically higher, numerically more complete responses, but still, not not as exciting as we thought it would be. And here, what's different from CTLA-4 is that the response was actually driven by PD-L1 more than 1%. So this trial just, is actually improving the responses of single agent nivolumab and chemotherapy. So in addition to, rather than focusing on a PD-L1 negative patient population, PD-L1 negative patients actually were on the other side of the bar. And another study here, this is Galaxy Lung 201. This study was only focused on TPS high patients, so PD-L1 more than 50%, where there were patients who received dostarlimab, which would probably be standard of care. It's an anti-PD-1 inhibitor, and then 3 different doses of belrestotug, which is an anti-TIGIT. Now, TIGIT has been an antibody that we were excited about a couple of years ago and then disappointed about, and then this we were a little excited about with the results here, where we saw that numerically much higher overall response rates to with the addition of anti-TIGIT to anti-PD-1. Again, I want to emphasize that here we're trying to improve the response of single agent immunotherapy that already works, rather than focusing on a patient population that doesn't derive as much benefit from anti-PD-1 therapy. What was concerning was there were 3 grade 5 events, all immune mediated. So we probably activated T cells a bit too much, leading to toxicity in 3 patients. So while there's hope with the numbers, there's concerns with toxicity. The next thing that I want to focus on is targeted therapy, and that is something that I actually do a lot of by treating non-smokers. So there's obviously lots of points where we can target different proteins that are involved in T cell priming, differentiation, or effector function, or even affect the tumor microenvironment. The first one is VEGF, and we've briefly talked about VEGF with Harmony-2, so I'll not go into that much detail, but VEGF antibody is secreted by tumor cells to lead to increased angiogenesis. VEGF is also known to be a mechanism for increasing MDSCs and causing a negative tumor microenvironment, immunosuppressory tumor microenvironment, so leading to lower responses to immunotherapy. The first time we used VEGF on a broader scale was in a SWOG's lung map trial, where there was a sub-study where investigators randomized patients into either standard of choice or Pembro and ramucirumab. These patients are patients who've already progressed on Pembro, so it's a re-challenge study. And the study was fairly positive, with an increase in median overall survival by 3 months, which was impressive in a second-line setting. And this led to a bigger study that has been conducted in SWOG right now called Pragmatica. And then I won't go into as much detail for Harmony-2, but Harmony-2 has a bispecific PD-1 VEGF, and compared to Pembro, which was a positive study for PFS, across all subgroups, and we saw commonly, expected adverse events like proteinuria and hypertension by inhibiting VEGF. Another one that I wanted to focus on, which was disappointing, was atezo-cabozantinib versus compared to docetaxel in second-line setting. Again, a re-challenge study with the addition of cabozantinib, and cabozantinib did not deliver like ramucirumab did, and it was a negative study. I just want to briefly mentioning that there's a lot of discussion on adding PARP inhibitor to immunotherapy, because PARP inhibition leads to DNA damage, which can activate the STING pathway, can lead to PD-L1 upregulation and increase antigen presentation, which are going to be helpful for T cell recruitment if we give immune checkpoint inhibitors. Actually, the phase 2 trial is called JASPER. So it was recently published, I think a year ago or so, and I think more studies are underway. There's also been some talk of antibody drug conjugate. Mechanistically, it makes sense to give chemotherapy in the form of antibody drug conjugates, which can lead to immunogenic cell death and then increase dendritic cell recruitment and T cell activation in the tumor microenvironment by its mechanism of action. There have been one study in NeoCOAST that was presented at World Lung, which showed that Dato plus immunotherapy as a concept led to more responses and more PCR in early stage non-small cell lung cancer. But in a second line setting, it was fairly negative. So TROPION-Lung1 was a negative study in overall survival. They saw a signal in PFS in squamous cell carcinoma, but overall it was negative. And then in the overall survival by histology, it was also negative. And another one of the ADCs, sacituzumab, in EVOKE-1 was also negative. So by itself, there might not be as much role, but then again, I think there will probably be combining it with other agents and bringing it frontline, as we've seen historically with how these drugs are developed. There are lots of other combination partners for immunotherapy. I've just briefly talked about what's recent and what's further along, but there are vaccines and cytokines that are being developed in this space, and there's a lot more to come. I just wanted to summarize by saying that anti-PD-1 are not being replaced in PD-L1 patients. I think we need a good drug which can probably replace docetaxel. And once we know that a drug works broadly is probably when it'll stand against pembro by itself. But then again, I think all these negative studies that we've seen in second line are probably going to be combined with anti-PD-1 with or without chemotherapy. And so we'll probably end up having a lot more options to combine with Keytruda or nivolumab or cemiplimab. And then we will have to figure out which combination will likely be best for the patient, which leads to us identifying more and more biomarkers that we've discussed in the last two talks, and also an avenue for what should be called precision immunotherapy. And that is my last slide, just summarizing all the different ways and we can look for biomarkers, radiogenomics, radiomics, digital pathology, ctDNA, imaging, and tumor microenvironment. And that is it. That is the end of my talk. Thank you so much.